Learn Efficient Pharmacology, Pharmacokinetics Part 7, Biotransformation in the Liver. We have seen that the body considers xenobiotics or foreign molecules as harmful. So the body changes the structure or biotransforms a xenobiotic so that it becomes more water-soluble and can be easily excreted. During this process, the xenobiotic usually becomes inactive. So where do you think a xenobiotic should be biotransformed? Wherever it enters the body. That is, at the portals of xenobiotic entry. This includes gastrointestinal tract, respiratory tract, and the skin. But what if a xenobiotic has already entered the circulation? There must be an organ to metabolize these. What kind of an organ? An organ that is very well perfused so that xenobiotics can be delivered quickly to it. The capillaries supplying the organ must be non-restrictive so that the molecules can be easily delivered to the metabolizing cells. The cells involved in metabolism must have an arsenal of enzymes that can metabolize most xenobiotics. And if this metabolism generates toxic intermediates, there must be damage control mechanisms in place. Even if some damage occurs, the organ should be able to repair or regenerate. And once the xenobiotic is transformed into a more polar form, it can no longer cross the membrane by simple diffusion. So, there must be mechanisms for cellular exit of the metabolite. You might have already guessed the organ that satisfies all these criteria. The liver, the rich blood supply, the sinusoidal nature of capillaries, the range of metabolizing enzymes within hepatocytes, mechanism for damage control, the ability to regenerate, transporters to facilitate cellular exit of the polar metabolite. And not one, but two paths for exit of the metabolite from the organ. One into the biliary canaliculi, where it is taken into the intestinal lumen dissolved in bile, or the other into the hepatic sinusoids, where it is taken to the kidney by the blood for excretion in urine. And in the chapter on absorption, we had discussed the logic of the anatomical placement of the liver. The liver is placed such that the orally ingested xenobiotic delivered through the portal vein can be intercepted before it enters the systemic circulation. And for xenobiotics that have already entered the systemic circulation, these can be delivered to the liver through the hepatic artery. But there is one problem here. The human body may be exposed to millions of xenobiotic molecules. How can liver address this massive challenge? Well, for that, we have to appreciate how the metabolic arsenal of the enzymes in the liver are organized. We know that the end product after metabolism should be water-soluble. One process to make this happen is to add or conjugate the xenobiotic with a water-loving or hydrophilic moiety. Such moieties include glucuronic acid, glutathione, or functional groups like methyl, acetyl, or sulfate. The resultant conjugate will be highly water-soluble. Such conjugation reactions are mediated by conjugating enzymes. But having an enzyme and a hydrophilic conjugating agent is not enough. The xenobiotic molecule should have an acceptor site. This can be an oxygen, nitrogen, or sulfur atom. A drug with such an acceptor site can be readily conjugated. This is what happens with the familiar drug acetaminophen, also known as paracetamol, a drug used to treat pain and reduce fever. Acetaminophen already has an acceptor site in the form of the oxygen atom of the hydroxyl group. It is here that the conjugating agent glucuronic acid attaches. the resulting glucuronide conjugate is highly water soluble. This is the major metabolite of acetaminophen. Alternatively, the oxygen atom can accept a sulfate group. So, in addition to glucuronide conjugates, a significant proportion of acetaminophen is also excreted as sulfate conjugates. But what if a xenobiotic does not have an acceptor site for conjugation? Then the body has to introduce one so that the xenobiotic can be conjugated. An example is phenytoin, a drug used in the management of seizures. Here, first, a hydroxyl group is introduced to form hydroxyphenytoin, and then the glucuronal moiety is conjugated to the oxygen of the hydroxyl group. The highly lipid-soluble phenytoin has now been biotransformed into a highly water-soluble glucuronide conjugate, which can be excreted in the urine. Here, what we saw was in fact two phases of metabolism. One phase involved glucuronide conjugation. The other phase, a reaction to facilitate conjugation, involved hydroxylation. It should be obvious by now as to which of these should be phase 1. Hydroxylation, because the hydroxyl group has to be first present for transferring the glucuronal moiety onto the xenobiotic. Obviously, glucuronide conjugation is phase 2. So, after phase 2, a drug becomes more water soluble. But what if the molecule becomes highly water soluble after phase 1? Then, a significant fraction of the drug can be excreted without further metabolism. One example is the drug paclitaxel used in the treatment of ovarian cancer. Similarly, what if the molecule is already polar or ionic? Neither phase 1 or 2 might be necessary, and most of the drug could be excreted unchanged by the kidney. An example is the drug gentamicin used in urinary tract infections. Hydroxylation and glucuronide conjugation are just examples for phase 1 and phase 2. There are many other reactions too. We shall see those in detail in the next video. Here is a good to know fact. Here is a summary of our discussion.